Welcome to the Funnel Effect. We are diving deep today into, well, a really significant document. It outlines kind of the future of minimally invasive cardiac care. It's the SCAI position statement on intracardiac echocardiography to guide structural heart disease interventions.
Yeah, this is a critical piece of guidance, absolutely essential reading. It's published in the Journal of the Society for Cardiovascular Angiography and Interventions. And, for anyone tracking how cardiac procedures are evolving, the author list alone tells you a lot. It's Makram Efalid, MD, FSCAI, leading a really comprehensive team. You got Christine J. Chung, Matthew J. Daniels, Vivian Demas, Andrew M. Goldswise, Harsh Gowala, Eric M. Horlick, Matthew J. Price, Carlos E. Sanchez, John T. Saxon, Marcus D. Scherer, Gilbert H. L. Tang, D. D. Wang, and Omar K. Khalik. Quite the lineup.
Wow, yeah. That roster definitely signals the weight of the topic, the shift we're discussing here. And our focus today, it's really driven by necessity, isn't it? Structural heart disease interventions, SHD, they're just evolving so fast. And these new procedures demand better imaging, real-time, less invasive intraprocedural imaging. It feels like we're moving away from just acceptable guidance to meeting precision steering.
Exactly. That's the core of it.
Mm-hmm.
And our mission today really is to give you a shortcut to understanding this whole transformation. We want to explore how intracardiac echocardiography, or ICE, is shifting. It used to be more of a supplementary tool, right? Now it's moving towards being a foundational pillar for guiding these procedures.
Okay.
So we'll compare it head-to-head with the traditional gold standard, transesophageal echo T. And maybe most importantly, we need to really dissect the big hurdles, the systemic stuff, particularly the financial and logistical barriers that are stopping it from being used everywhere.
Okay, so before we jump right into the comparison, let's just quickly define ICE for everyone. It's an imaging method, uses a catheter, usually up through the femoral vein, right?
Correct.
And it gives you these high-resolution pictures of heart structures, but from inside the heart chambers. But here's the kicker, the big takeaway, right up front, clinically and operationally. Because it doesn't go down the throat, ICE guidance often means you can skip general anesthesia. And that change, moving from GA to conscious sedation, that seems like a total game changer for patient recovery, for hospital flow, everything.
It really, really is. It changes the entire peri-procedural experience.
Okay.
Okay, so to really grasp why IC is becoming so important, we kind of have to start with the reigning champ, T. Three-dimensional T, usually run by a dedicated interventional imaging physician. That's the current gold standard, no question. The image quality is, well, often described as unparalleled, and there's a solid technical reason for that.
Okay, and what's that technical reason? Why are the T pictures so good?
It basically comes down to the probe itself. The T probe is pretty big, it has to be, to sit comfortably but securely in the esophagus. And that size lets engineers pack in a huge number of high-resolution ultrasound crystals. We're talking hundreds of elements sometimes.
Ah, okay. More crystals, better picture.
Pretty much, yeah.
Well,
That density of elements directly translates into, well, better resolution, a wider field of view, better frame rate. You get this expansive, highly detailed 3D picture of the heart's anatomy. And that quality is absolutely vital for complex stuff, especially like mitral valve repairs, where you need incredible precision.
right, so you get these amazing, beautiful images, but like you said, it comes at a cost, pretty significant cost to the patient and, well, the whole system. The source document doesn't really mince words about the downsides of TE, does it?
No, it's quite direct.
Since that probe goes down the esophagus, it pretty much mandates general anesthesia, often needs intubation, airway protection, which suddenly bumps the procedure up from minimally invasive to something needing a full anesthesiology team, the recovery time associated with GA. It's a bigger deal.
That's exactly right. And then there are the inherent risks you have to consider. It's a recognized risk, low, but recognized, of esophageal injury, just from manipulating that probe, which can take a while, during complex structural heart cases.
Right, you're moving it around quite a bit back there.
You are, and that risk means a more cautious approach, maybe a longer recovery room stay afterwards, just making sure everything's okay with the anesthesia and the esophagus.
And I saw this source also mention specific anatomical issues that can just completely rule out TE. It's not just about comfort. It's like you literally can't use it sometimes.
Exactly. These anatomical restrictions, they just take T right off the table.
Yeah.
If a patient's had, say, a prior esophagectomy, or they have really tight esophageal strictures where the probe can't pass safely, or even a big hiatal hernia that messes up the probe positioning behind the heart, T just isn't a safe option. And in those cases, the team has to find another way. Or maybe the procedure can't even happen with T guidance.
Okay, so this is where IC really starts to look attractive, where its value proposition changes the whole discussion. The ICE catheter comes in through a vein, usually the leg, so it completely avoids all those esophageal problems.
Completely.
And if you can dodge GA, use conscious sedation instead, avoid that esophageal injury risk. That sounds like it leads directly to faster patient recovery. Maybe even same-day discharge for procedures that used to mean an overnight stay.
Absolutely. That's one of the major drivers.
Yeah.
Faster recovery, earlier discharge. It improves the patient experience and hospital throughput. And, proximity is everything in ultrasound imaging. The source makes a good point that IC can sometimes overcome imaging limitations that T faces.
How's that?
Well, T needs a clear acoustic window from the esophagus to the heart. But what if the patient's heart anatomy is really distorted? Or there's shadowing from, say, prosthetic valve hardware or heavy calcium? T images can get really fuzzy or blocked in those situations.
Right. But the ICE catheter is inside the heart, especially the right heart chamber, so it's right next door to the action, avoiding those shadows.
Precisely. Its position, often in the right atrium or right ventricle, lets it get much closer to the structures you need to see. It can often get superior images of things that are tricky for T, like the tricuspid valve, which is very interior, or parts of the interatrial septum.
Yeah.
We'll definitely come back to that.
Now, you mentioned IC isn't brand new tech. It's been around for decades.
Yeah.
But the source seems clear that older limitations, hardware, software, maybe image quality, kept it mostly for simpler cases.
Yeah.
So what's changed? Why this big SCAI statement now?
The big change is really the advancement in 3D ICE hardware and software. That's what's making it viable for more complex interventions. But we absolutely have to be honest about the current limitations, too. The main one is still a resolution gap compared to T.
Okay.
Current IC catheters are limited by size, right? They had to fit through veins. So we're talking maybe 9 French up to 12.5 French. That size constraint means they just can't pack in as many ultrasound crystal arrays as those big TE probes.
Fewer arrays means lower native image resolution. Is that the idea?
Yes, fundamentally. And it's not just about image clarity. Fewer elements can also mean a smaller sector with, like, the angle of the picture you capture.
Mm-hmm.
And potentially slower frame rates, too, which can make tracking fast-moving devices or heart structures a bit more challenging, especially on the left side of the heart where T has always been so strong.
And then operationally, it gets complicated again. You mentioned the human factor. Maintaining that optimal image, especially during tricky 3D procedures like checking a device seal in the left atrium. IC often needs a second person, right? A dedicated operator.
Yes, that's a critical point. For complex 3D ICE, you often need a second dedicated operator, an interventional imaging physician. Their only job during the procedure is to manage the ICE console, steer the catheter tip electronically or mechanically, and optimize the image. They work alongside the physician who's actually doing the implant or repair.
So that's a big workflow change compared to maybe simpler 2D ICE use where the interventionalists might manage it themselves.
A huge workflow change. And this dual operator model brings up both procedural challenges and, as we'll discuss later, major financial hurdles. Plus, we have to consider the unique risks of ICE itself.
Right.
You're putting a catheter inside the heart, transvenously. So there's always that small inherent risk of complications, cardiac perforation causing arrhythmias, and just the risk associated with getting that extravenous access site specifically for the imaging catheter.
And the learning curve. You said the views aren't fixed like TE. They depend on where the catheter is sitting. That must take some getting used to.
It definitely does. The source points this out clearly. There's a steep learning curve. Operators new to ICE can potentially misidentify landmarks or not position the probe optimally, which could lead to technically unsuccessful procedures or just make them take much longer than needed.
Makes sense. That's why standardized training becomes so important.
Crucial. Absolutely crucial.
Okay, let's talk about the hardware that's trying to bridge this gap, though. Because the paper names specific systems, these advanced 3D ICE devices. Things like the AccuNav volume from Siemens, the New Vision from Biosense, and the Verisight Pro from Philips. And the specs look quite different.
They are quite different. It shows the evolution. Look at the AccuNav volume. It's a 12.5 French catheter, relatively large for ICE, but it only has 128 elements. Now, compare that to the New Vision, which is smaller at 10 French, and the Verisight Pro, even smaller at 9 French. But both of those boast 840 elements.
Wow, okay. That's a huge jump. From 128 to 840 elements, that sounds like the key difference, aiming for much better resolution.
That's exactly it. That massive increase in element count is the clear indicator that this newer generation of ICT is aggressively trying to match keys resolution and image clarity. It allows for much better native 3D rendering.
So NuVision and Verisight Pro are really pushing the fidelity.
Absolutely. But beyond just element count, each system has its own sort of unique features to help the operator. The Akina volume, even with fewer elements, has this really useful feature called one-click MPR, multiplanar reconstruction.
PR, okay.
Yeah, it lets the operator instantly slice the 3D volume into different 2D planes like coronal, sagittal, axial to precisely pinpoint a location or measure something. Very handy.
And the other two,
Yeah.
Vision and Verisight Pro.
The NuVision, the 10 French one, it features independent distal tip rotation, so the very end of the catheter can be steered separately. That mechanical flexibility is really helpful for navigating tricky anatomy and getting just the right image plane without having to twist the whole catheter shaft. And the Verisight Pro, the smallest at 9 French, uses digital 20 steering. So instead of mechanically moving the tip as much, you can electronically steer the imaging plane within the 3D volume that's already been acquired, gives you real-time flexibility.
Interesting. But the common features across all these advanced systems really show the direction, right? They all do 2D, M mode, Doppler, pulse wave, continuous wave, color flow, live biplane imaging, and the big one, live 3D with color. The investment is clearly there to make ICE a comprehensive imaging tool, even if that resolution gap with T isn't totally closed yet.
Precisely. The goal is full functionality from inside the heart.
Yeah.
All right, so as we start using these powerful new ICE tools for actual procedures, standardization becomes really key. The source document really hammers this home. Having standardized imaging acquisition angles, standard names for views, it's not just academic neatness, it's critical for training effectively, for quality assurance across procedures, for building that muscle memory operators need, and just for clear communication within the team. Everyone needs to be on the same page.
Yeah, I found that distinction they made really interesting. Between ICE and, say, TTE or T, they said paraprocedural ICE isn't meant to be a full diagnostic exam like the others. It has to be laser-focused, tailored specifically to the intervention you're doing right now.
Exactly.
You're not necessarily trying to hit the exact same textbook view every single time because the catheter's position will vary a bit patient to patient.
That's the fundamental difference. The catheter's flexible, it's inside a moving heart, its position relative to structures changes.
Right.
So the critical skill isn't hitting some predefined precise angle. It's rapid, accurate recognition of the anatomical landmarks wherever they appear on your screen. And then the skill to manipulate the catheter subtly to keep those key structures perfectly in view as the procedure progresses.
Okay, so let's lay that foundation then. Where do these ICE-guided procedures typically start? What's view number one?
It starts with what they call the home view. This is your baseline. You advance the ICE probe from the femoral vein up the IVC and into the right atrium, the RA. From that standard spot, you get a good look at key right-sided structures. The tricuspid valve, TV, you can usually see the aortic valve cusp sort of peeking through, and the junction of the RV inflow and outflow tracts. Just confirms your basic orientation.
Got it. Home view in the RA. And then from there, you manipulate the catheter to see other things, especially to get across to the left side.
Yes, it's a sequence of controlled specific movements. So from the home view, a gentle clockwise rotation usually brings the mitral valve into view. Then if you rotate clockwise even more and maybe add some posterior flexion, kind of pushing the tip slightly backwards toward the spine, that maneuver optimally shows you the interatrial septum, the IAS.
Okay.
And mastering these basic rotations and flexions, that's the essential groundwork for pretty much any left-sided structural heart procedure that needs transeptal access.
Right. And the main reason for doing all that is usually the transeptal puncture, the TSP, either for just measuring pressure in the left atrium or more often for getting those bigger delivery sheaths across for putting in devices.
Exactly. And TSP guidance is really an area where IE can significantly outperform T because the IC catheter can be positioned right up against the septum, often giving you much clearer, closer images of the fossa ovalis and the potential puncture site. T, being further back in the esophagus, can sometimes struggle to get really crisp images, especially for puncture sites that are low down and posterior on the septum. The angle and distance can be tough.
So for something like a left atrial appendage closure, an LAAC device, which often needs a specific inferior and posterior puncture, IC might actually be better positioned geometrically to guide that accurately.
Absolutely. The source highlights this, and it specifically mentions the role of the new 3D ICE capabilities here, especially multiplanar reconstruction, MPR. MPR lets the physician take that 3D volume of the septum and slice it in real time into different 2D planes.
Hmm.
So you can precisely pinpoint the intended puncture location relative to surrounding structures like the aorta or mitral valve.
And that location is critical, right? It changes depending on the procedure.
Hugely critical. It has to be tailored. For LAAC, you generally want an inferior, slightly posterior puncture to give the device delivery sheath the right trajectory towards the appendage. But for complex mitral valve repairs, like MT ear, you often need a more mid-septal or even slightly superior and posterior puncture to align the large delivery system correctly with the mitral valve leaflets. Getting that spot right is crucial for success.
Okay. And safety during TSP is obviously paramount. The position statement really emphasizes specific safety checks under ICE. What are those?
Non-negotiable safety steps. First, you have to meticulously check for any pericardial effusion fluid around the heart, both before you puncture and immediately after. Any new fluid is a red flag.
Right.
Second, you need to assess the tenting of the interatrial septum as you push the needle against it. You watch how far it bulges or tents before the needle pops through. You want to see this clearly in both long-axis and short-axis views to make sure you're safely on the fossa and not aiming somewhere dangerous.
Okay, tenting.
And third, there's a really important rule for the operator during the actual puncture itself, especially when using fluoroscopy alongside ICE. Avoid adjusting the needle or sheath in more than one dimension or plane per fluoro image.
Ah, okay. Why is that rule so critical? Avoiding movement in more than one dimension at a time.
It's all about control and minimizing the chance of a catastrophic error. When you're advancing that sharp needle towards delicate structures, if you try to adjust it, say, anteriorly and superiorly at the exact same moment while looking at a 2D fluoro image, you dramatically increase the risk of misjudging its true 3D position and accidentally puncturing the back wall of the atrium, or worse, the aortic root.
Ooh, okay.
So sticking to just one adjustment per fluoro confirmation step, move anterior, check fluoro, move superior, check fluoro ensures very careful, controlled, deliberate movement. Absolutely essential for safety.
Makes perfect sense. Okay, moving on to PFO and ASD closures. The source kind of positions these as the natural training ground for operators new to IC.
Yes, they often are. PFO closure is a foundational ICE-guided procedure, and ICE allows for this really rapid, detailed assessment of the patent foramen oval right there on the table. An assessment that might have been, less detailed or even deferred in the pre-op T. A really important part of this intraprocedural assessment is identifying specific anatomical variants that might increase the risk of leftover shunt after you put the device in.
Okay, what kind of variants are we talking about? What does ICE help you spot there?
The source specifically calls out things like a prominent Eustachian ridge. That's a little fold of tissue near where the inferior vena cava enters the right atrium. If it's really big, it can act like a ramp, directing blood flow straight from the IVC right at the fossa ovalis, making a right-to-left shunt more likely.
Interesting.
Another key one is a septal aneurysm, where the septum itself is floppy and redundant, kind of bulging back and forth. ICE gives you crucial detail on the length of the PFO tunnel, the degree of overlap between the septum primum and secundum, and the mobility of that aneurysm. All that info helps you choose the right size and type of closure device and position it correctly.
And the classic diagnostic test during these closures is the bubble study, injecting agitated saline. The source talks about doing it from both the SVC and IVC. Why both?
Yeah, this is a really critical nuance they highlight. The standard ICE protocol for PFO assessment calls for bubble injections from both the superior vena cava SVC and the inferior vena cava IVC. And the reason reveals something important. Relying only on the IVC injection often underestimates the true size or significance of the shunt coming from the SVC in maybe up to half of patients.
Really? Why is that?
It's a washout effect. The strong blood flow coming up from the IVC can literally sweep the bubbles away from the fossa ovalis before they have a good chance to cross over, making the shunt look smaller than it is. Flow from the SVC often has a more direct path to the fossa, so if you only inject IVC bubbles, you might miss or underestimate a clinically important shunt. You really need both views.
Wow, that finding alone really underscores the value of doing this detailed imaging right there during the procedure.
Absolutely.
Okay, now for ASD closure, specifically the most common type, the secundum ASD.
Right. For the secundum ASD closure, ICE guides sort of three main phases: assessing the defect accurately, guiding the device deployment, and then confirming the result immediately after. Key things you're assessing with ICE are the precise size of the defect, its exact location on the septum, and crucially, the adequacy of the supporting rims of tissue around the hole. You need good rims to anchor the device.
Mm.
During deployment, ICE helps you orient the closure device correctly, confirm its relationship to vital nearby structures, especially the aortic root anteriorly and the AV valves, mitral and tricuspid, inferiorly. You absolutely don't want the device impinging on those, and then afterwards you check carefully for any residual leak or shunt across the septum.
And thinking about that learning curve again, how does the complexity balance out for training?
Well, the recommendation is definitely incremental. You start operators with the lower complexity procedures, so PFO closures and simple secundum ASD closures, often using just 2D ICE initially. Build those foundational skills. The source suggests that 3D ICE, because it's more complex to operate, costs more per procedure with a disposable probe, and ideally needs that dedicated second imaging operator at the console. It's often reserved, at least initially during training, for the more challenging secundum ASDs, maybe ones with deficient rims or unusual anatomy where that detailed multidimensional view is truly essential for getting the device seated properly and safely.
Got it. Start simple, build up to the complex 3D stuff.
Exactly. Crawl, walk, run.
Okay, so if TSP, PFO, and ASD closures are kind of the training ground for IC, left atrial appendage closure, LAAC, seems like where IC has really exploded. It's demonstrated its power to change workflow and drive efficiency. Why has LAAC seen such a rapid uptake of ICE guidance?
Yeah, LAC is a huge area for IC growth, and the primary driver, overwhelmingly, is the ability to shift away from general anesthesia. LAC is becoming a very high-volume procedure in many centers. Being able to do it safely and effectively under conscious sedation, it just dramatically improves the whole process.
How so?
Well, better efficiency in the cath lab, faster room turnover. Much higher patient satisfaction. Avoiding GA is a big plus for most people. And it really facilitates same-day discharge for a large number of these patients. For centers doing a lot of LAC with operators experienced in ICE, this translates directly into significant time savings in the lab, freeing up resources, lowering overall cost per case.
So the argument is basically, yes, the disposable IC catheter itself costs more upfront than maybe just using TE, but you save so much on anesthesia time, staffing, recovery beds that it ends up being economically favorable, especially at volume.
That's exactly the equation administrators are looking at. The operational savings, the efficiency gains, they often outweigh that higher disposable cost. It creates what the source calls a positive halo effect on the institution's entire structural heart program, makes it more efficient, more patient-friendly.
Okay, let's get into the workflow then. The source lays out a pretty standardized protocol for doing LAA under ICE guidance. Can you walk us through those key steps?
Sure. The ICE LAAC protocol is very systematic, designed for safety and reproducibility. It usually starts, again, with the home view in the RA. Then you'll get some RV views, mainly looking for any unexpected pericardial effusion and just getting a baseline sense of LV function. Next, critically, you need to visualize the left atrial appendage itself, often from a view obtained by placing the ICE catheter temporarily in the pulmonary artery, looking back towards the LA. The main goal here is to rule out LAA thrombus.
Right, can't put a device in if there's clot.
Absolutely not. That's a critical safety check. Then, you come back to the RA septal view to guide the transeptal puncture, getting your sheath into the left atrium. Once you're in the LA, the focus shifts entirely to sizing the LAA orifice accurately and guiding the device deployment. And for this, the protocol mandates 4 specific LA views of the LAA.
4 specific views, what are they?
They're usually named by the nearby landmark they relate to. There's a mitral view, an aortic view, a pulmonic view, and a supramitral view.
Okay, and what is each view trying to confirm? It's not just getting a general look, right?
No, each one gives you a specific piece of information for sizing and ensuring safe deployment. The mitral view helps confirm the LAA dimension relative to the mitral valve annulus. The aortic view defines the dimension adjacent to the aortic root. The pulmonic view looks towards the pulmonary veins, making sure you have clearance. And the supramitral view often gives you that crucial orthogonal perspective, confirming the device is seated well within the appendage, it's not protruding into the LA body, and importantly, it's not going to impede mitral valve function.
Got it. So you need all 4 to really be sure about the size and the seating.
Exactly. Comprehensive assessment is key for long-term success and safety.
And for this kind of complex sizing and confirmation, is 3D ICE preferred over 2D?
Oh, absolutely. 3D ICE is strongly preferred for LAIC if available. The image quality is generally superior for defining the complex, often irregular shape of the LAA orifice. And crucially, 3D allows you to acquire multiple views simultaneously, or at least rotate the 3D volume digitally, with much less physical manipulation of the IC catheter compared to trying to get all those views with just 2D sweeps.
Makes sense.
And studies have shown that 3D ICE guidance is comparable to 3D TE for confirming good device seal, compression, and ruling out significant peri-device leaks after deployment.
But the source still emphasizes careful patient selection, right? A T isn't completely out of the picture for LAC guidance.
Correct. ICE guidance is considered particularly suitable, maybe even ideal, for certain patients. Those who are already on uninterrupted anticoagulation, where the thrombus risk is lowest. Those whose LAA anatomy looks straightforward and suitable on their pre-procedure CT scan. Patients with good kidney function, who can tolerate the contrast needed for angiography. And importantly, patients who can tolerate moderate sedation comfortably.
Okay. When would you definitely still choose T then?
T remains the preferred or maybe even necessary guidance method if there's any real suspicion of LAA thrombus on pre-procedural imaging. T's resolution is still considered the best for definitively ruling out clot. Also, if the LAA anatomy is particularly complex, maybe very posterior, or has multiple lobes that are hard to assess, T might provide a more stable, high-fidelity view.
Okay. Let's shift gears now to valvular interventions, starting with the tricuspid valve, the TV. This seems like an area where IC isn't just an alternative to T, but maybe even complementary or sometimes superior.
Yes, the tricuspid valve is a major growth area for ICE utilization, precisely because T faces significant challenges here. Think about the anatomy. The TV is the most anterior valve in the heart. The T probe sits way back in the esophagus, so you're often dealing with distance and awkward angles.
Right.
And worse, T visualization of the TV is frequently compromised by acoustic shadowing.
Yeah.
What causes the shadows? Really common things. Pacemaker or defibrillator leads crossing the valve, prior prosthetic valves creating artifacts, even large hiatal hernias that push the stomach up and interfere with the view.
But ICE avoids all that shadowing because the probe is right there in the RA next to the valve.
Exactly. By positioning the ICE catheter directly in the right atrium, you get much closer, unobstructed views of the TV leaflets, annulus, and subvalvular apparatus. You completely bypass those shadowing issues from leads or prostheses. So for the newer, complex tricuspid procedures like T-TEER, the edge-to-edge repair for the tricuspid valve, or TTVR, transcatheter tricuspid valve replacement, many advanced centers are now routinely leveraging the synergy of both 3D EEE and 3D ICE simultaneously.
Using both at the same time, how does that work?
Well, TE provides that excellent transgastric view looking up at the TV from the perspective of the right ventricle. It gives you great visualization of leaflet coaptation. Meanwhile, 3D ICE provides the complementary view from the right atrium, looking down onto the valve. This is often better for seeing the device delivery system interaction with the leaflets, assessing leaflet lengths, and guiding grasping. Combining these two simultaneous orthogonal 3D views gives the team the most complete, comprehensive picture possible of the complex tricuspid anatomy and the device interaction. It really helps ensure accurate repair or placement.
Makes sense, using the strengths of both. What are the key specific views ICE provides for a TV intervention?
Well, you start with the home view again. That gives you the overall trajectory. Then you need specific views to really assess the individual TV leaflets, their length, mobility, any tethering, which is crucial for planning a successful T-TEER grasp. And critically, during device deployment, you're using 3D IC, often with NPR, to assess the real-time orientation of the device arms, making sure the clip is grasping the leaflets correctly and confirming secure attachment without causing damage.
Okay. Now, shifting across the heart to mitral valvular interventions, specifically MTEER, the MetroClip procedure. Here, the consensus seems to swing heavily back towards T being dominant. The source said IC is used in less than 2% of MTEER cases in the U.S. Why such a strong preference for T here?
Yeah, the mitral valve, especially for edge-to-edge repair, remains firmly in T territory for the vast majority of cases. It really comes down to two main factors: image quality and reproducibility in the left atrium. The high-resolution, wide field of view, and stable imaging platform provided by T are considered absolutely essential for the millimeter-level precision needed to successfully navigate the left atrium, visualize the complex mitral valve leaflets, and achieve a durable grasp with the MitraClip device.
So ICE is really only used if T is impossible.
Pretty much. ICE for MTEER is generally reserved for that small subset of patients who have absolute contraindications to T, like severe esophageal disease, maybe prior esophageal surgery, or certain cervical spine injuries that prevent the neck extension needed for intubation and probe placement.
And if you do use ICE for MTEER, the procedural steps sound incredibly demanding.
They are significantly more complex than using T. First, you need that very specific transeptal puncture we talked about, targeted precisely to the mid to posterior fossa of the septum. And guiding that puncture accurately relies heavily on excellent 3D ICE and MPR skills. Then, once the ICE catheter is actually in the left atrium, you have to position it very carefully, often trying to keep it parallel to the plane of the mitral valve to get the optimal imaging window of the leaflet tips where the clip needs to grasp.
And the source mentioned a big practical problem, the IC catheter interfering with the M-tier delivery system. Can you explain that? Why is it such an issue?
It's a physical space problem, basically. The MPR delivery system is quite large, relatively stiff, and it needs to be manipulated extensively within the left atrium to position the clip. The IC catheter, which needs to be positioned delicately nearby to get those crucial views, is easily bumped, pushed, or shadowed by the movements of this much larger M-tier system.
Oh.
This constant interference means the imaging operator has to continually fight to realign the ICE probe, which is frustrating and time-consuming. In some challenging cases, the team might even decide the only way to get stable ICE images is to perform a second transeptal puncture, just to park the IC catheter safely out of the way of the M-tier system. That obviously adds significant time, risk, and complexity to the procedure.
Wow, yeah, that sounds really challenging. Okay, so beyond M-tier, does ICE have more utility in other types of mitral procedures?
Yes, it definitely does. Its value has been clearly shown in procedures like transcatheter mitral valve-in-valve or valve-in-ring interventions. In these cases, you're putting a new transcatheter valve inside a failing surgical valve or ring. Here, the primary guidance tool for positioning is often fluoroscopy, using the visible metal frame of the old surgical device as a landmark.
Right, you can see the old valve on X-ray.
Exactly. But ICE provides really critical complementary imaging in these cases. Before deploying the new valve, ICE helps assess the landing zone, make sure there's no thrombus or vegetation, and then, maybe even more importantly, it's used for immediate post-deployment checks.
What kind of checks are you doing after the valve is in place?
The crucial things you check with ICE right away are measuring the residual gradient across the new valve to make sure it opened well, carefully looking for any paravalvular leaks or PVLs around the edges of the new valve where it seals against the old ring, and checking for any acute complications like the new valve frame maybe impinging on the LV outflow tract or, rarely, obstructing a coronary artery. ICE's ability to show real-time blood flow with color Doppler and assess valve function often gives you much more immediate and accurate feedback on these things than angiography alone.
Makes sense. Okay, one more valve, the pulmonary valve, PV. For TPVR, transcatheter pulmonary valve replacement, where does ICE fit in there?
This is another area where ICE often provides clearly superior visualization compared to other echo methods. Trying to see the right ventricular outflow tract, RVOT, and the pulmonary valve with standard transthoracic echo, TTE, is notoriously difficult, especially in adults. You often have poor acoustic windows because of lung tissue, obesity, prior surgeries.
Right, the chest wall view is often limited, but ICE, being inside the RV,
Solves the problem immediately. By placing the ICE catheter directly within the right ventricle and RVOT, you get excellent close-up views of the pulmonary valve complex. So it's used pre-implantation to carefully rule out issues that might prevent TPVR, like active endocarditis, vegetations on the valve, or significant pre-existing paravalvular leaks around a prior surgical conduit. And then post-implantation, ICE is essential for checking for immediate complications right on the table.
what kind of complications after TPVR?
Things like inadvertent injury to the nearby tricuspid valve during device placement, assessing for any new paravalvular leak around the TPVR frame, and checking for acute dysfunction of the new valve leaflets themselves. Again, ICE is often much better than angiography for assessing leaks accurately, as fluoro can sometimes show false pseudoregurgitation just from the catheters and wires temporarily interfering with valve closure. ICE gives you the true hemodynamic picture.
Okay, so we've really established that ICE is, technically speaking, a very powerful tool. It's versatile, it's minimally invasive, it drives efficiency, improves patient comfort, sounds great. Yet, despite all these clear advantages, its adoption isn't universal. And you made the point earlier that the biggest barrier holding it back isn't really the technology itself anymore, but these systemic issues, specifically money, reimbursement.
This is absolutely the crux of the matter, and it's a major focus of this SCAI position statement. It's arguably the most critical section for anyone thinking about implementing or expanding an ICE program, administrators, policymakers, physicians. Let's really break down this reimbursement problem because it's quite stark. Currently, the professional reimbursement for the physician performing the ICE guidance relies on just one single add-on CPT code, current procedural terminology code. It's plus 93662.
One code for all ICE guidance.
Okay,
And what's the value assigned to that crucial imaging work?
prepare yourself. It's valued at only 2.80 relative value units, RVUs.
2.8 RVUs? That seems incredibly low.
It is incredibly low. To put that in perspective, this tiny RVU value is supposed to cover an essential skill that requires years of specialized fellowship training, deep anatomical knowledge, sophisticated hand-eye coordination, and critical real-time decision-making during complex procedures. It's disproportionate.
And the problem isn't just that the value is low per se, it's that it's a fixed value, right? It doesn't matter how complex the procedure is.
Exactly. That's the killer. That low fixed value is the same whether you're using basic 2D ICE to guide a straightforward 30-minute PFO closure, or you're using advanced 3D IT with complex MPR analysis, potentially needing that second operator for a challenging 3 or 4 hour mitral or tricuspid valve intervention.
Wow.
The code simply does not recognize or reward the vastly different levels of technical expertise, cognitive load, or procedural time involved. It's a massive disincentive for tackling complex cases with IC.
And this loops back to that dual operator requirement for complex 3D IC. You said for things like M tier or T tier, best practice often involves a separate interventional imaging physician managing the ICE console. Does this CPT code plus 93662 offer any compensation for that essential second expert?
Critically, no. Zero. The current professional reimbursement structure provides absolutely no separate compensation for that second necessary specialist.
So if a hospital wants to follow best practices, ensure the highest level of safety and image quality for complex ICE-guided procedures by having two dedicated experts.
They have to figure out how to pay that second expert, the imaging physician, essentially out of pocket, or through some internal hospital arrangement. There's no direct reimbursement pathway for their crucial contribution.
That sounds like a major barrier to scaling up complex ICE programs, especially maybe at smaller centers or places without big academic budgets.
It severely limits the scalability, absolutely. It either restricts complex ICE to high-volume centers that can absorb the cost, or it potentially puts pressure on the implanting physician to try and manage both the intervention and the complex 3D imaging simultaneously, which the source strongly implies compromises procedural safety and efficacy.
So the SCAI statement isn't just describing the tech, it's making a pretty strong policy argument. They're saying the current payment system effectively penalizes institutions for using the safest, most advanced techniques in structural heart care.
It's a very clear call to action. They argue forcefully for the creation of new tiered CPT codes. Codes that actually reflect the technical complexity, the time involved, and the specialized expertise required for guiding different levels of structural heart interventions with ICE. In the meantime, until those codes exist, they strongly advise institutions to implement formal internal mechanisms, like revenue-sharing programs, to ensure fair compensation for the interventional imaging physician. Recognizing that this collaboration isn't a luxury, it's essential for safe, high-quality outcomes in complex cases.
Okay, so fixing the codes is crucial long-term. But in the here and now, institutions still need a strategy to implement ICE successfully, given the high initial cost of the consoles and the ongoing cost of those single-use IC catheters.
Absolutely. Implementation requires careful planning and tracking. The source suggests that hospital administrations should actively track key metrics using ICE scorecards.
Scorecards. What kind of metrics are we talking about?
Things like average procedure times with IC versus T for comparable cases, documenting anesthesia utilization rates, how often are you truly avoiding GA. Tracking overall structural heart procedure volume is ICE helping the program grow. And this tracking isn't just for show, it's about evaluating what they call the halo effect.
Okay, let's define that halo effect. What proves the value beyond just the procedure itself?
The halo effect is the sum of all the positive downstream impacts that help offset the upfront costs of the ICE probe. So key metrics would be things like calculating the average time saved per case by avoiding GA setup and recovery, quantifying the reduction in anesthesia provider costs, measuring faster patient turnover in the cath lab and recovery areas, and assessing the potential growth in the overall structural heart program because the hospital gains a reputation for offering efficient, minimally invasive procedures with conscious sedation.
Makes sense. You need to prove the business case.
Exactly. And the source recommends rigorously reviewing these metrics after, say, the first 25 and then the first 50 ICE-guided procedures of a certain type to really measure that return on investment and justify the ongoing institutional commitment to the technology.
Okay. And the final piece of the puzzle for successful adoption is training. We talked about the steep learning curve, especially for the complex 3D stuff.
Yes. Robust, standardized training pathways are absolutely essential. You can't just hand someone a 3D ICE catheter and expect expert results. That's why the SCAI document proposes a very detailed three-tiered model for achieving ICE expertise. It's designed to build skills and confidence incrementally.
All right, can you walk us through those three levels?
Sure. Level I is the foundational level. This focuses on mastering basic 2D ICE technology. The key skills here are reliable transeptal puncture guidance and confidently guiding straightforward PFO and simple secundum ASD closures. The document suggests a minimum experience of about 10 ICE-guided transeptal procedures to achieve level I competency. This builds that basic hand-eye coordination and anatomical recognition.
Okay, level 1, basics, TSP, simple septal defects. What's level 2?
Level 2 moves into intermediate complexity. The primary focus here is left atrial appendage closure, LAAC. This requires utilizing more advanced 2D and perhaps introductory 3D ICE features. It also involves integrating IC imaging with pre-procedure CT planning to accurately target the specific fossa location needed for LAD. This demands a higher level of anatomical understanding and image fusion. The suggested minimum here is around 20 IC-guided LAEs procedures, acting as the primary operator responsible for imaging guidance, sizing, and deployment confirmation.
Got it. Level 2, LAAC integrating CT, more advanced IC use. And then level 3 must be the top tier.
Level 3 is the Advanced Comprehensive Expertise level. This applies specifically to using complex 3D IC for guiding the most challenging procedures we discussed. Intricate mitral and tricuspid valves interventions, like M-tier and T-tier. This level absolutely mandates that dual operator approach we talked about, the highly skilled imaging physician on the console working synergistically with the interventionalist manipulating the therapy device. The experience requirement here is significant, reflecting the difficulty. The source recommends a minimum of 20 ICE-facilitated complex mitral and 20 complex tricuspid procedures. This level of skill is typically only acquired during dedicated, advanced structural heart interventional fellowship training.
Wow, okay, that's a serious commitment to training. Looking forward then, what does the source say still needs to improve with the technology itself?
Well, even with the advances, there's still room for improvement to try and fully close that gap with T, especially for left heart imaging. They identify needs like continued improvements in 3D image quality, particularly resolving structures further away from the probe, achieving a wider sector width to capture more anatomy in a single view, and developing probes with even greater steerability and flexibility, perhaps making single operator control more feasible for a wider range of procedures in the future. The ultimate goal is matching or even potentially exceeding T image quality while keeping all the benefits of the minimally invasive intracardiac approach.
But the big takeaway, the overriding theme, it really comes back to those systemic barriers, doesn't it?
It really does. Technologically, ICE is already incredibly capable and rapidly improving. The biggest hurdles are systemic. Developing that robust, tiered reimbursement system, one that actually recognizes and fairly compensates the essential, often separate role of the interventional imaging physician that is paramount. Without adequately valuing that expertise, which is critical for safety and optimal outcomes in complex cases, the full potential and widespread adoption of ICE, especially beyond major academic centers, will remain limited. And alongside that, the field still needs more high-quality, comparative clinical outcome data, ideally from randomized trials, directly comparing IC versus T guidance for the most complex mitral and tricuspid interventions, just to further solidify IC's role based on hard evidence. Hashtag outro. So to kind of wrap up this deep dive, intracardiac echocardiography, ICE, is clearly a powerful, highly specialized imaging technology. It's truly minimally invasive, and it's fundamentally changing how we approach structural heart disease interventions. It enables complex procedures to be done, often under conscious sedation, which is a huge win for patient recovery and overall procedural efficiency.
Right. But the key takeaway for you, listening to this, is that the path for ICE to become the universal standard, well, it isn't really being blocked by the technology itself anymore. The devices are getting incredibly sophisticated. They often provide geometrically superior views for certain structures. The real roadblocks now are systemic. It's things like an outdated, flat CPT coding system that just doesn't reflect the complexity of the work being done. And it's the need to standardize and properly support these rigorous physician training pathways, including fairly compensating that essential dual operator expertise for complex cases.
Yeah, and maybe here's a final thought to leave you with, something to chew on. We have this incredibly sophisticated, life-saving structural heart technology, advanced 3D ICE, that inherently requires highly specialized skills, often from two physicians working in perfect synergy. Yet the current payment system values that critical precision imaging guidance with a single, flat, marginal CPT code that hasn't evolved alongside the complexity of the procedures it enables. So the question becomes, if we can't find a way to align our reimbursement structures with the actual demands of procedural excellence and safety, how can we ensure that this revolutionary care can be scaled safely and effectively to all the institutions and all the patients who need it? That tension between advanced capability and outdated systemic support really defines the challenge for the future of minimally invasive cardiac care.
Thank you for watching The Funnel Effect.